Good evening. Thank you for joining us for tonight's Lung Life webinar, Asthma Control, Avoiding the September Spike with respiratory therapist and educator, Cinde Little. My name is Jill Hubick. I'm a registered nurse and certified respiratory educator with Lung Saskatchewan. It is my absolute pleasure to welcome you and to be your host and moderator this evening. Before I begin the presentation, I would like to acknowledge the land that I am hosting this webinar on is Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as the territory of the Métis. We would like to acknowledge the many First Nations, Métis, and Inuit whose footsteps have marked these lands for generations, and we are so grateful to be able to host this event where we are. On behalf of Lung Saskatchewan, I would also like to take a moment to acknowledge the healthcare providers and champions in lung health. Healthcare providers have definitely gone above and beyond during the pandemic. They continue to do so each and every day. We are so grateful. So to all the healthcare providers, thank you so much from the bottom of our hearts and our lungs. The pandemic certainly has been challenging on all of us. It is especially challenging for people with lung disease. Supporting and helping people living with and caring for people with lung disease is a priority for Lung Saskatchewan. We offer a variety of support groups for patients and caregivers. The support groups include asthma, COPD, pulmonary fibrosis, COVID-19, lung cancer, lung transplant, sleep apnea, and Saskatchewan Quits to help people quit smoking. These support groups are there to help those living with lung disease or those who want to quit smoking navigate their journey in a supportive way. Tonight's presentation topic, Asthma Control, Avoiding the September Spike, was requested by some of our Lung Saskatchewan asthma support group members, as they have shared with us that early fall is often a time where they experience worsening of asthma symptoms. We hope this webinar helps you breathe easier. If you're not a member of our Lung Saskatchewan support groups and you'd like to be, we would love to have you. Simply visit our website, lungsas.ca, to register. We are so excited about our presentation tonight. Cinde is a registered respiratory therapist, certified respiratory educator, and certified tobacco educator who has worked in asthma education for 25 years. She is currently an education consultant for Alberta Health Services and works with the Community Pediatric Asthma Service in Calgary, providing asthma education to people in family doctors' offices. Cinde is also a trainer for the nationally recognized RESTREC program that trains healthcare providers to become certified respiratory educators. In her free time, she uses her health education and knowledge as a food blogger and volunteers with the Calgary chapter of the Canadian Celiac Association. We are so grateful to have her tonight. I'm sure we will all learn something from Cinde. Following her presentation, we will have time for a moderated question and answer period. So if you have questions for Cinde, please type your questions into the question feature of the webinar software. You will find this feature in the control panel on the right-hand side of your screen. And don't be shy to ask your questions. Chances are someone else has a similar or the same question as you. Cinde's presentation is actually the fourth webinar of our 5-part 2022 Lung Life Educational Webinar Series, which is sponsored by GSK. Lung Saskatchewan and GSK have a long history of working together on activities that improve the lives of those living with lung disease. This new education webinar series, Lung Life, is to empower those living with and caring for those with lung disease to live better. Just like you've joined us for this webinar, We hope that you will join us for our final webinar of the Lung Life series on November 22nd at 7 p.m. Central Standard Time for our Physio Yoga, a wellness celebration of Lung Month. We also have recordings of all our past webinars posted on our website if you missed them. So here is a short video highlighting the past recorded webinars from this series, as well as our upcoming webinar. This series would not have been possible without GSK, a science-led global healthcare company with a special purpose: to unite science, technology, and talent to get ahead of disease together. This webinar series is one example as to how GSK and Lung Saskatchewan have worked to move ahead together. I'm so pleased to welcome Marie-Claude from GSK to bring greetings and to welcome our presenter.
Good evening, everyone. My name is Marie-Claude Desaulniers, and I am the Patient Engagement Manager at GSK. We are a proud sponsor of the Long Life webinar series presented by Lung Sask. It has always been a pleasure and a privilege to partner with Lung Sask in the past and to continue to do so as we share the same objective, which is to help people live with lung disease like asthma to live a better life. You're probably like me at this time of the year and saying, where did summer go? Well, if someone in your family or yourself is living with asthma, you are probably aware of what's coming in September. So welcome to this educational webinar, Asthma Control, Avoiding September Spike. Enjoy tonight's presentation.
Hi, thank you to Saskatchewan Lung for having me present on this topic tonight. It is asthma control, avoiding the September spike. My name is Cindy Little. I'm a registered respiratory therapist, certified respiratory educator, and certified tobacco educator. So I think everyone knows now what a respiratory therapist is from the pandemic. But I work for the Community Pediatric Asthma Service in Calgary as part of Alberta Health Services, and I provide asthma education to people in the community and in some Alberta Health Services community locations, as well as family doctor offices. I'm also a ResTrek trainer and faculty mentor for Lung Saskatchewan, and I've been doing that for more than 15 years. So I'm happy to talk on the topic of asthma control. So I have no disclosures to make. My only disclosure, this is the group I work with. It's an older picture, but we're a pediatric group and we have lots of fun. So we did the Seven Dwarfs one Halloween. And the picture on the right is where I was last week when I perhaps should have been looking for slide or photos for my presentation that didn't have copyright images. So I did the best I could. So thank you all for joining us. So what is the September spike? So it is a predictable annual rise in hospital admissions, emergency room visits, and family doctor visits for childhood asthma. So it occurs in many Northern Hemisphere countries, Canada, the United States, Finland, Trinidad, Mexico. Many countries have reported this annual spike. Now this work is from Malcolm Sears, a physician many of you might know, and he finished this study in 2005, I believe was first published. I'm referring to 2007. And he determined that 20 to 25% of all childhood asthma worsenings requiring hospital occur in the month of September. So that's, almost jaw-dropping. 25%, a quarter of all the hospital visits happen in the month of September. So it's certainly worth, as educators, as people with asthma, it's certainly worth knowing that and trying to prevent that from happening. So learning to control your asthma. This graph is a picture from the same work that Malcolm Sears did, showing the repetition of the emergency room spike. So this is the September spike, the September peak, some people call it. So it is from 1990 to 2004, so over 14 years, and it's so perfect it almost looks like an ECG recording. So it's showing us that clearly there's an underlying cause that's factors that happen every year at the same time. So what might those be? So when I'm talking to patients or families with children with asthma, I call this the perfect storm. So in the fall, we have viral infections, a common flu. People are exposed to allergens, late summer allergens, early fall allergens, both indoor and outdoor. Many people are off of their routines. They tell us that openly, that they just haven't been on the routine. Either their asthma's been well controlled, they think they don't need the medication, or they just haven't been able to keep up with the routine. So many different reasons. And then some countries also report cooler weather as a factor in the September spike. So before we talk about what we can do about the September spike, I just wanted to address COVID-19, of course, the impact it has had on the September spike. So I think that will come in years to come. People will look at the data and find out what the impact has been. And this is a paper from 2020, so that's already 2 years ago, when children were first going back to school. And they predicted, or they showed, that some people had improved overall asthma control, but not all. So the factors considered were decreased vaccination rates. Of course, there's been controversy about vaccines, and the regular flu vaccine is always recommended for people with asthma, all people with asthma, not just children. Delayed management of health conditions, we've seen this lots. People did not want to go to emergency. They didn't want to sit there and possibly get COVID. They weren't comfortable with even going into a doctor's office. Doctor's offices maybe couldn't accommodate them. They couldn't get seen. Lots of factors there. Prolonged exposure to indoor home pollutants is another factor to consider. Children could have been at home for all these extra hours, and there may be allergens in their own home. Of course, impact on mental health for everyone, entire families are affected by that. So this is all from a study from 2020 about asthma and return to school. But I just wanted to add in there anecdotally, cough. Many people who have told me that they missed lots of school, weeks of school from cough, parents missing lots of work, and children being sent home with cough that they knew wasn't COVID. They tested negative for COVID repeatedly. And of course, that is a sign of poorly controlled asthma. So by the time I'm seeing people and hearing this story, I think it's a very common story that the pandemic has affected children in that way. Right here, I'm going to show you a video called Back to School with Asthma. It's about the September spike. And it is from our colleagues at the Children's Allergy and Asthma Education Center in Winnipeg. They do an excellent job on allergy on their website and their videos. And so this is a YouTube video. She's going to talk about the September spike, and then also about asthma in general and the symptoms and the treatment. So it's just 3 minutes, and we'll just skip to that video right now.
In Canada, there are more emergency room visits and hospital admissions for children with asthma around the 3rd week of September than any other month of the year. This is known as the September peak. Some of the effects of this time of year include children not able to attend school, participate in activities, parents missing work, and more hospitalization for kids. So why is September such a bad time for asthma in children? One reason is that cold viruses like rhinovirus are common triggers of asthma, especially in school-aged children. Returning to school allows children to easily spread colds to others, and colds make asthma worse. Pollens such as ragweed, outdoor molds from farmers' fields, smoke from burning fields, and pollution because of busy traffic are often triggers that are worse in the fall and can contribute to worsening asthma symptoms. Another reason for the increase in asthma problems in September can also be the lower use of controller medicine during summertime. So how can we avoid asthma problems this fall? First, let's look at asthma. Asthma occurs in the airways inside our lungs. Notice how the muscles on the outside of these normal airways are relaxed and how open the airway is, allowing air to go in and out easily. Asthmatic airways are always a bit swollen on the inside. This is called inflammation. Controlling inflammation is the key to keeping asthma controlled. The muscles surrounding asthmatic airways are tight, making it harder for air to get through the airways. Mucus is also produced inside asthmatic airways. Symptoms of asthma are coughing, wheezing, shortness of breath, and chest tightness. Before going back to school, it is important to get asthma in control. Asthma control looks and feels like breathing normally, being able to participate in normal activity without coughing or wheezing, sleeping well at night without asthma symptoms, and not needing any reliever medicine like Ventolin. Before your child returns to school in the fall, it is important to start or increase their controller medicine. It is always important to avoid your child's allergy triggers and never allow your child to be around cigarette smoke. To prevent colds, teach and remind your child about the importance of good hand washing and to cough or sneeze into their elbows. These are effective ways to stop the spread of cold and flu viruses. Have a doctor checkup before school and follow your child's asthma action plan. Speak to your doctor about when to start or increase your child's controller medicine. The most important thing is to be sure your child's asthma is under control, especially as they prepare to go back to school.
Okay, so now we're moving on to what is asthma control. So that video from the Winnipeg group, certainly you can add that to your toolkit if you work with children or have a website that you want to share that with, share that at school, anywhere that you can spread the message about asthma and asthma control, so asthma awareness. So this slide I've got referred to the latest 2021 Canadian Thoracic Society guideline update, and it's talking about the goal of treatment. So asthma treatment, we want to achieve well-controlled asthma to minimize both short-term and long-term complications, morbidity, and mortality. So for people who are not familiar with those words, morbidity is the missed days of school, the sickness from a disease, rather than the mortality is dying from a disease. So morbidity includes lost days of work, lost days of work for parents, etc., and missing out on regular everyday activities, not being able to attend family parties or whatever activities people have. On the right-hand side is a picture of our bookmark. We have this bookmark. We actually had this on our poster, still have this on our poster presentation that we take whenever we go somewhere and do a presentation. And it is the simple steps to asthma control. So that's what we're going to talk about now, really for the rest of the presentation. So it's just a reminder, to me, it's a reminder that it's such a simple message. It's the same message. We're still trying to get the same message across. So avoiding triggers, taking your medication, checking your devices and technique, and following your action plan. So that's how we think you can achieve asthma control. Okay, so the same guideline update. So these are the Canadian Asthma Consensus Guidelines. When we talk to patients and families, we want to make sure that they understand this isn't just an idea that someone had in their mind. This is all well documented, and we're practicing providing education to patients, completing asthma action plans to a very high standard. So people will often think symptom control. If you think of being an emergency for asthma, or if you think of going and seeing your doctor, people want to have their symptoms controlled and their symptoms to go away. but we're actually looking for complete control. And in the guidelines, it's telling us, yes, symptoms and impact on quality of life. Those are some of the things that I just mentioned. Exacerbations or worsening. So exacerbation is the medical word, but a worsening of asthma. We also want normal lung function. Many people have never had their lung function tested, and it is the gold standard to measure asthma. So we wouldn't know your asthma was well controlled if we didn't have a lung function test to also prove, as well as the other factors that go with it. So it's very important. And then in people with more moderate to severe asthma that are being followed by a lung specialist at a tertiary hospital, they can measure inflammatory markers like sputum eosinophils and other factors that they would use to measure well-controlled asthma. Now this slide here, I'm going to take a few minutes to explain it. And every time I see it, or the last time that I saw it, I said to my colleagues, we really should figure out how to turn this into a nice, not infographic, but like a pictorial representation of this very, very important message. So asthma control takes time. And this message is something we talk to people about all the time. Everyone's focused on decreasing their medication, stopping their medication. And I'm just going to walk through it. So there's acronyms all over here. So on the bottom, we're looking at months, not weeks, but months. So very long-term control. On the left, we're looking at 100% improvement. So the first lineup is no night symptoms. So if you came to me with poorly controlled asthma, we treated you with the right medication, whatever, and you would have no nighttime symptoms within days or a week. This is showing like closer to a month, but it would be very quick that we could resolve your nighttime symptoms. The second number is the forced expiratory volume at 1 second. So this is the number, the most common number that we use from the breathing test that we can measure the openness of your airway. And you can have a normal forced expiratory volume at 1 second within, this is showing 2 months in this graph. I would have said shorter, but certainly 2 months. And it can be even longer in people who have had long-term untreated asthma. So I have seen that take much longer in some people to get to a normal forced expiratory volume. Now the morning peak flow. So although we don't use peak flows a lot in family medicine or community asthma, we do use peak flows in emergency rooms because they're quick and easy, and we also use them in clinical trials. So people might take a peak flow meter home and measure their peak flows. So we know from doing research that it takes months for those morning peak flows to be fully within normal range after taking the proper asthma medication. Now the next is the short-acting beta agonist. So this is the salbutamol or Ventolin medicine, that people know the name of that. And it takes, in this graph is showing 6 full months before someone has asthma so well controlled that they do not need their blue puffer. So I would say to people who think that their asthma is well controlled, but they're still needing their blue puffer, that maybe you should think twice about that. And for people with asthma who are watching this presentation, this is kind of like a hot topic, and it's a really great topic to talk about. So the current guidelines let us use our blue puffer a couple times a week, and we're working with people to understand, why do you need it a couple times a week, and do you really need it a couple times a week? Can we get better control of your asthma? And then the far-reaching one at 18 months is airway hyperresponsiveness. So when I'm talking to people with asthma, I talk about asthma as being twitchy, sensitive airways. So when I do your breathing test, back to that forced expiratory volume, when I do your breathing test, it's measuring the diameter of your airway. So it can be completely normal, but yet your airways, you still have these twitchy, sensitive airways, and they're reacting to things in your environment. So it takes a long time to, some people might say completely heal the airways, or resolve that airway hyperresponsiveness. So there's a lot to take in there, and it's a great picture that we're always talking about. Okay, so now I want to talk about exacerbations or worsenings. So in the guidelines, they specifically talk about a severe worsening. So when we talk to people, we should be using plain language. Worsening is a great word, and some guidelines have encouraged us to use the word worsening instead of exacerbation. We want people to get these concepts so that they can fully understand how to manage their own asthma. So a severe worsening is any change in your asthma that requires systemic steroids. So that means oral steroids, tablets in adults. It could be intravenous in emergency, or it could be liquid for children. And sometimes family doctors will give systemic steroids, and sometimes you will get them at emergency. But the need for systemic steroids is telling us you had a severe worsening in asthma. This is what we're trying to prevent in September and all year long. Or an emergency room visit. So for people health professionals who work in emergency, they're so used to seeing people in emergency that there was a time when those people didn't realize that a simple, you call it simple emergency room visit for asthma is telling us you had a severe worsening, that you had to go for help. And some of those people will be admitted to hospital. So again, those are the three criteria that we would use to define. Any one of those is what we would call a severe worsening. Now in the guidelines, they do talk about a mild worsening. So that's an increase in your asthma symptoms from baseline that doesn't require any of the above. So you're able to manage it at home, and hopefully you're able to manage that with the medications that you have, other strategies, and an asthma action plan. Okay, now I know there's lay people watching this. This is actually a graph for healthcare providers, but I also wanted to show it just to be comprehensive and meet the needs of the audience here. So this is the, I'm calling it a graph. I think it's maybe a picture representation. So for the way we treat asthma, has been since the original guidelines in 1999. We start at the bottom layer of the image so that confirm the diagnosis there. Health professionals always want to be thinking, does this person have asthma? Is there anything else complicating it? Or is it even masking it as something else? So that's an important piece. The second layer there, I've circled that with the red line, is environmental control, education, and a written asthma action plan. So these two have been in the guidelines forever, since the beginning, and they are applicable for every single person. So everyone should have asthma education, and everyone should have an asthma action plan. And the confirm the diagnosis is the breathing test that I mentioned. Okay, the next bar is the short-acting beta agonist, so everyone should have a blue puffer. And the newest change in the guidelines is the addition of this as needed combination medication, which I'll come back to. But the other things I wanted to point out, so the triangle, as the triangle goes up, we see an escalation of medication. So if you have more severe asthma, you need more medication. That's is typically how we think of it. But the line, the gray arrow that goes all the way from the bottom of the yellow peak of the triangle to the top is reminding us that the goal of asthma treatment, we need to adjust the therapy to achieve control and prevent future risk all the time. So when we see people who were sent home from emergency and they got treatment for 1 week, those people are at risk of coming back to emergency. And it's very important for family doctors, all health providers, to recognize that we need to do some extra education to try and prevent that future risk. And for people who have had that happen, then you might have to seek it out if you were not followed up after an emergency room visit. And then also, again, on the left-hand side, regularly reassess control. The first, I just circled that, the first one is always control. We're talking about control, but also preventing future emergency room visits. Okay, so the next slide is asthma action plan. So this is what I would call like the most important tool. And the most important tool in our toolbox to provide people with an understanding of their asthma and a way to control it. So the action plan is, in Canada, we have 41. The last time I checked, there's 41 different asthma action plans. So that might tell us that there's good uptake. People have created action plans and are using them. The guidelines have been telling us since 1999 that everyone with asthma should have an asthma action plan, and it should be individualized for their care. However, if there's 44 of them available, that means it can be challenging for family doctors and other people to know which one to use, to recognize them. If you see different ones all the time, then you don't recognize them. So really, it is the job of a respiratory educator, an asthma educator, to complete asthma action plans. Some family doctors do it, some pharmacists do it, but wherever you are in the asthma world, I just encourage you to promote them, use them, promote the use of them in all areas that you work with. So the one on the left is, I know it's not entirely clear, but I wanted to point it out because we call it the Little Asthma Plan. And we came up with this, I'm going to say 15 years ago. And we have that little plan. It goes with a short video that's on our website that has some sounds but no words. And then we have this action plan translated into 14 different languages. So that is available on our website, and I will show you that later. And it can be used for adults and English with the second language. And we print actually all the asthma, the basic asthma information is in that if you follow through to our website and get that those 14 different languages. To the right of it is the Alberta Asthma Action Plan. This was also created about the same time, so I'm going to say 15 years ago. It has been updated, I believe 2018 might have been the last update. It does get updated as the guidelines change. And although it's a very small picture, you can see, if you look close, you can see the little pictures across the top. The guidelines tell us every asthma action plan should address triggers so people can identify triggers to manage their asthma. It's got a space for the symptoms, and then it's got the traffic light format. So this is recommended in the guidelines. If you're building an action plan, the traffic light format is green for good to go or well-controlled asthma. The yellow light is pay attention to the small signs of worsening. And the red light is out of control, go to emergency. So in my work, I'm mostly talking to people about the yellow zone. When you ended up in emergency, what happened the day before? What happened 2 days before? You missed all those signs. So people will say it just happened suddenly. And it didn't just happen suddenly. I mean, in preschool children, they can end up in the hospital pretty darn quick. They're pretty small and they have small airways. But for the most part, people have some signs. They need to actually understand what they are, and they need to have some action that they can take to manage their worsening. So that's the asthma action plan, and it is available on our website in English, French, Punjabi, and Chinese. I think I got that right. Okay, educational tools for asthma. So everyone needs educational tools. I'm going to give a plug to a colleague of ours who came up with these airway models. So at a presentation we talked about how our airway models were looking worn and we couldn't get new ones. And she has created a company called Respiralux. And you can see in the bottom of the photo there, the airway model set. She was making them at home with a 3D printer and has since gone on to print them. And I've got my set sitting right here. There are 3 airways, the regular, a little bit of worsening, a little bit of swelling in the airways, and then the tightening and the increased mucus you can see hanging over the top there. And kids like to pull that mucus out. So you can actually even reorder the mucus. So this is great for respiratory educators. If you are working somewhere and don't have any airway models, this is a perfect thing to buy. And then they also came up with the alveolar model set for people who work with COPD. So that's a brilliant tool that's available. We also need placebo devices. Again, with the pandemic, things have changed. We're changing the way, the availability of tools we have, what we carry with us, what people want to have, want to share. Placebo devices can be very good. We know that if people can't take the medicine or aren't taking the medicine correctly, then we can't get asthma control. So asthma educators need to have a lot of tools and be able to assess all the areas and find the errors to help people achieve their best asthma control. Spacers in the picture here on the right-hand side, it's pretty old, but it's probably very accurate. Only 9% of patients use their inhalers correctly. So this is a huge area for respiratory educators and to promote proper use and proper understanding in their area of work. So whether it's whether you work in a hospital, clinic, or anywhere, promoting proper use of devices and understanding how to use them is super important. We also need to have medically accurate information that's up to date. So there are old guidelines, and the guidelines get updated on a regular basis. So we want to be able to practice to the guidelines. So there's Canadian guidelines. In Canada, we should be practicing to the Canadian guidelines. The GINA guidelines, so I've got written here, Canadian European Respiratory Society and GINA. So GINA is the Global Initiative for Asthma. And also I would say the UK and New Zealand are also leaders in asthma. So we want to know what other countries are doing, what other groups are doing. And I would say we've been practicing to the GINA guidelines, which have a stricter, a higher criteria for control for several years now. And they were the first to have the latest change, which is using combination therapy for as needed treatment in asthma. And we'll come back to that later. So we just want to have ways that we can give people accurate information, make sure that we're following the latest thinking and the treatment for asthma. And so for everyone, getting your hands on those, and if you're a respiratory educator, you're the person who reads those documents and helps to transmit the messages in them. Access to printed materials as needed. So I see a lot of respiratory people who are taking the course to become a respiratory educator using all online tools. And of course, the pandemic has changed things. And of course, there are great resources online, but some people still need and value printed materials. Sometimes they see it. If you're seeing them in an appointment setting, this is the time they've set aside to come and talk about their asthma. If they have questions and you can give them printed material that answers their questions, that will be way more valuable than saying, of course they have a phone, of course they could go to any website. People who come home and go, oh, I wonder what's new with asthma. I think I should check that out. People have other things to check, like cat videos or whatever. So I think it's really important for us to recognize, would you like printed material? Having printed material available, saying sometimes in the old days before the pandemic, I would put it on the table and say, that's on our website. If you want to take it, you can. And that's a really good way to see, no, lots of people don't want to take it. And we're using less and less all the time. But I think it's important to recognize that for someone who wants it, that you have something available or you know how to get it. We want to make sure credible resources, so people who are going and searching the web can be coming up with resources from all kinds of different places and not even knowing or realizing that it's from like a different country or a message that you would say is maybe not as reliable. So of course in Canada we have Lung Association, RespTrek, the Canadian Asthma, Canadian Society, Asthma Society of Canada, and our website and lots of other websites and videos. And we still use resources from other countries as well. There's nothing wrong with that. Just being aware that you do need to have your toolbox, and for respiratory educators, you need a pretty big toolbox with lots of stuff in it. Okay, now I want to come to the treatment for asthma. So in asthma, we have inhaled corticosteroid, so I put that first as the controller medicine, short-acting, the reliever medicine, so SABA is the initials, and I'm just including that because it shows up everywhere. Long-acting beta agonist, so that's an add-on medication to the inhaled steroid, and then combination medicine, so these are the reliever and the controller, and then biologics, the medications used for people with severe asthma that's managed with a specialist. So this picture on the bottom is an older picture, but it just shows you that there's the different categories of medication. The blue on the bottom is what we've called sort of considered the long-term treatment of, the first line treatment for asthma, the reliever medication, salbutamol or Ventolin, and then the anti-inflammatories on the left. So those are the controller medicines. And then the long-acting bronchodilators are the ones on the far right. And in the middle is the combination medicine. So this picture sort of suffices for most people. And the combination medicine is a combination of the anti-swelling medicine, the inhaled steroid, and the long-acting beta agonist. So that's the long-acting Ventolin-like medicine. So the most recent work has been with those two medications combined in the same puffer. Nowadays, there's many more names. I'm not going to go over the names of them, and there is updated charts available. But to me, the most important messages are that the inhaled steroids is the most important treatment for asthma. Asthma is all about inflammation or swelling in the airways, and that's the medicine that treats the swelling. And then the short-acting is the reliever medicine that works quickly but wears off. And then the long-acting must be used in combination with the inhaled steroid. And then the combinations together, we're going to talk about that. Okay, so I just wanted to say that asthma treatment changes over time. So we all need to read and learn. Guidelines are a guide. We treat people with asthma and we need to help them. So we need to be understanding that things can change and treat people, meet them where they are and help them understand. Knowledge translation is slow. This is so apparent the older you get, and we need to help make change where we can. I just wanted to give these few examples. So in 1999 was when the Canadian Thoracic Society came out with the first asthma guidelines. So the asthma consensus guidelines collated together with a group of specialists from across the country saying this is the basic need for asthma. Every patient should have asthma education and every patient should have an individualized asthma action plan. That was said in 1999. I see people every day that have never had an asthma action plan and have never actually been for asthma education, which is what we as asthma educators provide. So 13 years later in 2012, I just picked these two things to mention because in 2012 was when the guidelines added no reliever use for exercise. So previous to that, you were allowed to use your blue puffer for exercise anytime you exercise, and that wasn't included in the criteria for well-controlled asthma. So I still see people all the time who have not got that message yet, so that's 10 years later, have still not got the message and they're using their blue puffer for exercise all the time, and no one has recognized that that's a sign of poorly controlled asthma. Now in 2021, the Canadian Asthma Consensus Guidelines have most recently come up with this update, which I would say much needed and much welcomed update. So they've combined the previous guidelines. There was a guideline for preschool children, a guideline for mild and very mild asthma. And if you think about the messages that we're trying to give to people, even to translate this information, transfer it to the family doctor level, it's becoming so complicated. They have to keep up on every single disease. And then there's guidelines. We had like 5 different guidelines for asthma alone. So in the new guidelines, they have combined everything, and they accept the guideline for severe asthma. And they left that open to say that we might add the severe asthma guideline. We might incorporate it into future updates. Sorry, just checking my time here. Okay, so the latest update in those guidelines, the most talked about update, there are many small nuances, things that respiratory educators should be aware of and understanding, and they are the as needed use of combination therapy. So in mild asthma, typically we have only had inhaled steroids with an as needed blue puffer. And these newest guidelines have shown that people can use a combination medicine. So we're talking specifically about Symbicort, the one that's got budesonide. I just put this here for health professionals, budesonide and formoterol. That's the abbreviation that we use, BUD form. And now people with mild asthma can use a short-acting, inhaled steroid, and the formoterol is the long-acting, but it works quickly, so it's a fast-acting. I don't mean to make this confusing, but using it on an as-needed basis. And there's the trial called the Sabina trial, short-acting beta agonist in asthma is how they got that name, Sabina trial, and that was one of the trials that we've heard a lot about lately, and showing that we can use this medication in people who have mild asthma. Now, before I show you this video, I just wanted to talk about the difference in the messages that we give people for asthma. So this is a video from New Zealand, and their approach for this using the term anti-inflammatory reliever medication. They're calling it air-based therapy, so everyone has a different way of explaining it. But what I want you to pay attention to in this video is for a deeper understanding of the effect of the variable nature of asthma and how adherence affects that. So he does a nice graph. It's a 3-minute video, and I think it explains it quite well, and you can watch how it goes up and down, and how this, I think people are asking, how can you take a controller medicine as needed? But this shows, I think this is an excellent presentation to show how you can do that. So here we are with the video on the anti-inflammatory reliever-based therapy for asthma.
Welcome to this video animation of the anti-inflammatory reliever-based therapy for asthma. Air-based therapy is the use of a 2-in-1 combination inhaler containing both a corticosteroid and a fast-onset beta agonist, used as a reliever instead of a short-acting beta agonist. The combined inhaler is used when needed to relieve symptoms. Let's take a closer look at the rationale for this approach. Asthma is a disease in which the activity fluctuates with time. Occasionally asthma attacks will occur, and these can be mild or severe. Regular scheduled maintenance treatment is prescribed for baseline disease activity. This results in periods of overtreatment, but also periods of undertreatment. However, adherence can be less than 50%, which means that maintenance regimes may be undertreating asthma most of the time, and they do not adapt to increased treatment need during attacks. So how does air therapy, taken as required to relieve symptoms, work? If symptoms are getting worse, patients can take extra anti-inflammatory reliever treatment as needed. This tops up the steroid treatment to match the severity of the attack and reduce how severe it becomes. In moderate and severe asthma, the same inhaler is used for both maintenance as well as the relief of symptoms. Regular scheduled maintenance treatment manages the baseline disease activity. As needed reliever use titrates the dose of anti-inflammatory treatment to what is required to manage asthma flares. In mild asthma, however, the disease activity is lower, and so only as needed treatment is required. There is strong scientific evidence from randomized controlled trials that the air-based therapy reduces the risk of severe exacerbations across the spectrum of asthma severity. If we look first at the panel on the left for patients with mild asthma, compared with a short-acting beta-agonist taken solely as reliever therapy, a combined ICS fast-onset long-acting beta-agonist drug taken solely as reliever therapy reduces the risk of a severe exacerbation by between 60 and 64%. If we turn now to the right-hand panel, in patients with moderate to severe asthma taking maintenance ICS-LABA therapy, compared with a short-acting beta-agonist reliever therapy, if they take the combined ICS-LABA as reliever therapy, this will reduce their risk of a severe exacerbation by between 20 and 44%. Based on this evidence of better outcomes, safety and ease of use, air therapy with a combined inhaled steroid fast-onset long-acting beta-agonist is now recommended as the preferred reliever therapy rather than a short-acting beta-agonist in adolescents and adults across the spectrum of asthma severity.
Okay, thank you for watching that. I hope you found that helpful to see how we can make sense of people taking a medication as needed. When you have a worsening of your asthma, there is more swelling in the airways, and so using the medication as needed makes sense. I think the most important point for all of us, people with asthma, people supporting family members with asthma, and people who are health professionals interacting with people with asthma, is to really understand the individual. So when we talk about providing an individual asthma action plan, we want to make sure that that your lifestyle is incorporated into those changes, and that we can provide the right information, ask the right questions to really determine if you do or do not have well-controlled asthma. So I think it's going to be a very small percentage of people who can use as needed therapy, as we're discussing, but it is a great way for people to have the right medication and get a taste of what their improved quality of life would be with that medication, and whether they need to take it every day or learn that they need to take it more often will be determined over time. But I can see how this will help many people in understanding how well controlled their asthma is. Now, I'm going to end on this thunderstorm asthma. This is kind of random, but what I want, the message that I want to bring, why it's not so random, is that we think people have well-controlled asthma, and the biggest mistake we make is not asking the right questions. And I think I'm actually going to go back and find the asthma action plan. Here it is. I know it's small, but I just want to draw your attention to the asthma action plan on the bottom right-hand corner. So when we talk to people with asthma, the guidelines are telling us that it's individual asthma care. We're treating people so they can figure out what their triggers are. That might take time. They can tell us what their symptoms are, but we need to ask and we need to help them figure that out. I know you can't quite see the words, but we're saying the definition of well-controlled asthma is no symptoms during the day, no symptoms at night. So that means no early morning cough, no need for your blue puffer. So I would just say you shouldn't need it very often. Physical activity. Physical activity should be normal. You should not need your blue puffer to do physical activity. and then not missing any more school or work than anyone else. So that's what we call well-controlled asthma. Now, before I get back to the thunderstorm asthma, I just wanted to talk about the way that we ask questions. So as educators, we know it's important to, I mentioned, use plain language, but we need to ask people and we need to give them the chance, so to be quiet and listen to what their answer is and make them think. So people will think. If you're a person with asthma and you wonder, has anyone ever asked you that? A couple of examples, someone I know, he would be asked, how's your asthma? And he's like, fine. And this is a relative of mine who then finds out that he's been taking his blue puffer for 20 years and his blue puffer does what it's supposed to do. And so he says fine to that question. But the question could be, how often do you use your blue puffer? Why do you use it? When did you last buy it? I mean, people can check that out. If they don't know, people can check. And we're just trying to help them. And when he had controller medicine, after I told him about it and he learned what it was, and he said, he texted me, why did you not tell me about this miracle medication? And it just reminded me that back in whatever year that was, 1999, when we knew that inhaled steroids was the medication for anyone who had asthma with symptoms every week. So that's over 20 years to actually get the right treatment. So we do see this all the time. And for respiratory educators, it's really the goal of our work is to be able to support people and find those patients. And sadly, they're not hard to find. So these messages of understanding of why do you use your blue puffer? How often do you use it? Just to go through the action plan. So in the yellow zone of the action plan, some people know that their asthma is worse, but they don't actually know what they can do. And another important message for respiratory educators and for people who live with asthma is the reliever medicine. On the bottom of that asthma action plan, that word reliever, we changed it from rescue to reliever more than 10 years ago. And every week I see someone who didn't take their reliever because they thought it was only for emergency. They took it in the car driving to the emergency department. They were afraid to take it. So they didn't fully understand when would you take a reliever medicine to relieve symptoms of asthma. This is to manage asthma. If you're going to do a 5K run or your kid's playing soccer and they have shortness of breath, that's what they need it for. They should take it. So that's not really a rescue. So I think what I'm getting at is the messages that people get. We all give people with asthma messages, and it's the people with asthma who have to try and figure out, is this message appropriate for me or not? So when you're in the emergency department, the messages you get are to keep you out of emergency, to treat you right now with what's happening and why you presented to emergency, and then to send you on your way, hopefully with follow-up with the family doctor, if you understood that or if they got that message. So that would vary across the country, whether that was able to happen. But the messages you got in emergency are not the kind of messages I'm giving people. I'm teaching you how to stay out of emergency. So I want you to know how to use the blue puffer, when to use the blue puffer. I want to find out, do you take it with you on vacation? People always are thinking, oh, well, my asthma's good, so I don't need it. So these are all the nuances that an asthma educator would provide to someone to help them understand. And you can use the action plan for anyone. If they've been in emergency recently, then you might focus on the red zone, like what happened before that took you to emergency. If you have never been in emergency, maybe you've never had well-controlled asthma, but you've never been in emergency. So there's a lot of variation and a lot of questions to ask. The guidelines tell us we should review I went through that earlier, the action plan well, probably once a year for people on well-controlled asthma, with well-controlled asthma. So I tell people, I want to see you until you have an action plan that works and well-controlled asthma, or sorry, and a breathing test. So that's why I want to see you. The breathing test is for me, not for you, but you would be able to tell by your symptom control. So I'm going to go skip ahead now to the end here with this thunderstorm asthma. So this is a study from Melbourne, Australia, and it's just such a, I shouldn't say fascinating, it was a horrific episode that happened in one day in Melbourne, and they have noted now historically that it happens every 5 to 7 years. And it happened, this one, this picture is from as a result of the incident that happened in 2016, where in a matter of hours, this thunderstorm happened. It happened to be in high pollen season. It happened to be at 6 o'clock in the evening when people were just going from home to school, etc. Lots of people, and happened right in the middle of Melbourne, Australia. They had 3,500 visits to emergency for people who had asthma-related trouble. 10 intensive care unit patients, and 35 visits or 35 admissions to intensive care, and 10 deaths in less than a day. So this was a horrific learning. And so these pictures are available. And the things that I wanted to point out to us as educators or people with asthma, asthma is a variable condition and you just don't know. And the things you can do are, of course, have your asthma puffer. But what they also learned was of the people who ended up, those 3,500 people that ended up in emergency, half of them didn't have asthma. But on further questioning, they did have cough, wheeze, shortness of breath, waking up at night with cough and waking up at night with shortness of breath. Like they had all those asthma symptoms at some point previous to this incident. So that's a lot of people who don't realize they have asthma. Maybe they have very mild asthma. So if you have hay fever and asthma, then this would be applicable to you, that this kind of an incident could happen and severely affect someone and cause asthma deaths. So anyway, I just thought that this was an interesting example of something that has happened and does happen. And it behooves us as asthma educators to help people understand what things are applicable to them, to perhaps consider that allergy treatment is certainly for people who have asthma. Allergy treatment can be important, and in this case, life-saving. So recognizing that you have allergies and recognizing that they can be treated. So I just wanted to end on that. So thank you for your attention, and I think we're going to have a short Q&A here, and I'm happy to hear anyone talk about favorite resources they have and answer any questions that you have. Thank you.
Thank you so much, Cindy, for your presentation tonight. I'm sure now we will all breathe a little bit easier this fall with all that we've learned. Thank you so much. We really appreciate you taking the time and sharing so much information. You definitely covered a lot tonight. So Cindy's presentation will be posted on Lung Saskatchewan's website, the recording of tonight. So if you want to watch it again or share it with friends and family or their patients, you're welcome to do so. It'll be on our Lung Life Patient Education web page. And I'll remind everyone, if they have questions for Cindy, we have time to answer some questions. So just type them in the question feature of your software there. Don't be shy. We've got a few that have come in. So if you're okay, Cindy, we'll just get started with the question and answer.
Sounds good.
Okay. So the first question, and this was actually emailed in ahead of time, this individual wanted to know, are there pollutants not included in the air quality indexes that could aggravate asthma conditions?
So I did get this question. Thank you very much. And I know a little bit more today than I did yesterday on the health quality index. So the air quality health index in Canada is made up of three things: the ozone, the number of the level of ozone. I sort of looked it up here, what it is today in Calgary, nitric oxide, and particulate matter. So particulate matter includes like all the things in the air. So it's anything that is I think it's 2.5 microns or smaller. So it can get deep into your lungs. So it's kind of, to me, it's a bit of a hard question. If there's things in the air, they probably are included in particulate matter. So you might say, I'm allergic to this, or there's something in the air that's bothering me. I think that is included in the air quality index. But I did learn that at one time, sulfur dioxide and carbon monoxide were included in the air quality health index, and they were removed. And so the reasoning was that they were not associated with additional health risk. So it's considered that those three levels, ozone, nitrogen dioxide, and particulate matter, together, the three of those account for the health risk from the air quality. So I'm not sure, that's not really a yes or, maybe it's not really a clear answer, but I think that probably anything you're wondering about, you might be able to identify it, but I think it all comes in as particulate matter.
Perfect. Now, Cindy, to follow up with that, is that something that you often recommend to your patients is to check the air quality indexes? I know, I believe in Alberta as well, but certainly in Saskatchewan, we've had a lot of wildfire smoke in our air, and that is affecting patients. Is that something that you encourage patients to check before they go out and take part in activities outside?
They certainly can. I think most people aren't really that interested in it. Like, you just want to know, what can I do to manage my own breathing, right? So I remember hearing from an allergist several years ago at a conference that the air quality health index is more precise now, and you can, if you're like a nerd about it, you can track and find out what is in the air, and you could actually determine your own allergens if you weren't sure of what they were. So you'd have to be really interested in that. So certainly you can use the air quality index. When I talk to people, I would more often talk about control. How do you feel? Maybe you can see the smoke, or maybe you can smell the smoke. It bothers some people more than others. So you can wear a mask, you can not go out, you can use your puffer, you can take allergy medicine, like all those things that you can do. I just want to make sure that they know that they have all those options and they can do what works for them. So the air quality index is readily available now. And of course, you can check that quite easily.
Another tool in the toolbox, hey?
Right, exactly.
Wonderful. Okay, great. Okay, we've got quite a few questions here. Does asthma and the treatment required to keep it controlled? So if you're on a certain everyday controller medication, do you find over a person's lifetime that medication will need to change in order to keep people under control?
I would say asthma is a variable condition. It very may well change. It does not escalate as you get older or as you've had asthma longer, not at all.
No.
But certainly people develop allergies. Allergies can seem to be lessened or even disappear. You can move. So there's different environments.
Right.
And so certainly asthma is variable and it changes. And some people need to change their medication, like even within a year, by seasons, based on their own asthma.
Perfect. Thank you for that. Okay, so any tips as an educator? I know you work with a lot of people. Any tips on having kids with asthma start their medication before the asthma spike when they're feeling good and they don't want to take their medication because they're feeling good?
Yeah, back to school, start the first day of school. I mean, some people start a few days before school, but I think as a general rule, we always say start the first day of school. So we know that the spike happens like in the second or third week. And if you wait until then, you've probably already started to develop more swelling in your airways. And if you're the parents that are saying to me, every September this happens, I'll say, okay, you already told me you don't need to do it again this September. Just start when school starts. So that's what I
Okay,
would say.
perfect, perfect.
And I would
Um,
also add, let me add one more tip,
yeah,
is once daily medicine is much more easy for people to manage. So
right.
I would say, ask about that, move towards that. Some people are just using sort of an older regime of twice a day, and that, it just, life is busy, and once a day is easier than twice a day.
Gotcha.
Good.
Gotcha. Thank you for that. Great advice. Okay, you mentioned in your presentation when you were talking about peak flow readings, you mentioned that it's often used in clinical trials. It'll be used in emergency department because it's quick and it's easy and accessible. But is that something that you would recommend for patients to use at home to help them monitor their asthma in addition to symptoms and use of how often they're using their reliever medication?
So the answer is no, we wouldn't use it. So the guidelines discourage, you should not use it in children. It's not as accurate. But even in adults, we can teach you to recognize smaller signs. So sometimes for children, whatever they feel every day is normal. So if they feel a little bit of tightness every day, they're not going to tell you because that's normal. So we want to
Right.
make sure that children learn to describe what they feel, use words for it, and have access to medication. So then if they are taking their blue puff or more, then that must mean they're having symptoms, and then you need to just work with them to find out, to describe it and make sure that they're taking their controller medicine or upping that to to decrease the symptoms and get better control.
Perfect. Thank you. Thank you. We appreciate that. Okay, and you had talked about spirometry and breathing tests and explained in that graph the forced expiratory volume in 1 second. So thank you for that. And that's a measure we look at for determining if asthma is controlled. How young do you offer spirometry testing
Uh,
for children?
we start at age 6.
Okay,
So it's kind of a developmental thing. Your child doesn't have to be smart, and they can be brilliant. It's a developmental thing. It's nothing to do with how smart they are. So we attempt it at age 6, and lots of 6-year-olds can't do it, and the odd 5-year-old can do it. But again, it's just one measure, one piece of the puzzle. So we sort of look at the symptoms, the history, the effect of the medicine, and the breathing test. So those 4 things together. And so we would start at age 6.
perfect. Okay. And so um, because spirometry is, you'd mentioned, is a gold standard, certainly for diagnosing asthma, how often would you recommend someone with asthma have spirometry done, or when would they have it done if they've already been diagnosed with a spirometry test, for example?
Well, if you've never had it, you should have it done. You should just ask and get it done. So for the record, because no one knows what it is. And
Right,
if you have well-controlled asthma, the guideline doesn't make a recommendation that you should have a breathing test every year. Maybe after 5 or 10 years, you might feel like you want to check again. Or certainly if something's changed with your asthma, you're feeling like it's not well controlled. But there's not a clear guideline. But sadly, most people have never had one done. So getting one done and having that on file is a great first step.
perfect. So in follow-up, and you might recommend spirometry for this individual. My son is now 10, and for the last 2 years, I've questioned if they possibly have grown out of their asthma. However, after hearing your presentation, I'm thinking their asthma is more likely just under good control. What would you recommend to help confirm this? And can I ask my family doctor if should they be referred to someone like yourself, a respiratory therapist or a certified respiratory educator?
Absolutely, probably all of those things. You can certainly have ask for spirometry. Again, spirometry is just a test. You probably get more value maybe out of seeing a respiratory educator, and there's nothing wrong with having all of it done, like assessing it, doing the spirometry to confirm that it's within normal limits for your child's age, height, race, and gender, and going through the asthma action plan. So if you're asthma is over-treated, the way we would typically decrease is by cutting the inhaled steroid in half. So if your child's taking 2 puffs a day, we would decrease it to 1 puff a day. We wouldn't do that in the month of September.
No.
So even though you think, oh, that your child's asthma is really well controlled, I think I would just wait till October if you want to do that test, or a season when you know your child's asthma is typically quite well, right? We don't want to take an unnecessary risk. And it's not really that risky. You can decrease it, you're following the guidelines from your doctor, your asthma educator. You can decrease it, and in 3 days, if the symptoms come back, you can just go back to what you were at. And that's, safe and easy. And then it confirms for everyone, oh yeah, okay, we're on the right path.
Good.
So that's definitely
that's great practical advice. And I know we have people from all over this evening joining us. But for those that are in Saskatchewan, if you're looking to see or speak to a certified respiratory educator, there is a list of certified respiratory educators and their contact information on Lung Saskatchewan's website, lungsas.ca. Or if people have questions, they can also call Lung Saskatchewan. We have certified respiratory educators, including myself, that will answer our helpline as well. And so, Cindy, you're coming to us from Calgary. How can people in Alberta access a respiratory educator such as yourself?
So in the Calgary zone, you can ask your family doctor to be referred to the Community Pediatric Asthma Service. And I'm not quite sure how that works in Edmonton, but just go through your family doctor. There's lots of asthma educators available, and there are some asthma educators at pharmacies. They're, not as, there's not as many asthma educator pharmacists as there are pharmacists, but that's another avenue that you can try. And you can print those action plans right off the website and take them to your family doctor as well.
Right, perfect. Okay.
And I want to say just about the spirometry. It is readily available. Your family doctor can order spirometry and get the results. And that's just not the, it's still just part of the picture. It's not the whole.
Yeah, spirometry itself, as opposed to a full pulmonary function test, you're right, much more readily available. It's not something that needs to be done at the hospital or anything like that.
Correct, yeah.
Which is great. Okay, so yes, I was very fascinated as well when you talked about thunderstorm asthma. It's such a phenomenon that is a little bit shocking to hear, but also interesting, and I think that we can learn from it and from what the research that has been done, and there has been quite a bit, including some research done right here in Saskatchewan on that. So there's lots of comments saying that the thunderstorm asthma piece that you spoke to was something that people didn't know about, that they were grateful that you shared that. It was interesting. There's a question about that. Is there a time when you should take a reliever medication if you see a pattern with symptoms and thunderstorms?
If you see a pattern, that's when you should take it. Absolutely. Okay. No one else can tell you. If you think this is, this is affecting me, or I know this is going to affect me, that's exactly what you should do.
Okay. Okay, perfect. Thank you. Yeah, it really does speak to how everyone's different and everyone's asthma is different. Okay. And people saying thank you for all your great tips. You're very knowledgeable. Thank you for all that you've shared. We've got lots of comments coming in.
Thank you.
Sorry here. I have one last question I want to get to you here. Okay. Yes. Okay. So you had mentioned, you talked about guideline updates of asthma and how they have changed over the years. Do you know when the next update will be, or how often do they update guidelines? How does that work?
The GINA guideline, the Global Initiative for Asthma, is actually not a guideline. They annually update it, so it's much more precise and a lot more nuances in it. In Canada, this was a huge update to incorporate several previous documents. It's not going to be done every 3 years. It's not going to be done every 3 years.
Okay.
And we're still implementing, there's still things in it from 20 years ago that are not, the messages aren't clear out there. So I don't think that's a bad thing that it's not updated, in 3 years. There won't be a lot of huge changes.
No. Okay. Okay, wonderful. Well, I think that is all the questions that we have had submitted. I'm also mindful of everyone's time, and Cindy, of your time. So I just want to thank you so much for sharing your time, your knowledge, your passion. I mean, you have so much wonderful experience. We at Lung Saskatchewan are also very grateful that you are a rest check trainer and helping to train healthcare providers across the country to help other people breathe easier. Thank you so much for all you do each and every day. And you shared such wonderful information and a lot of great information. So again, a reminder, tonight's webinar will, in the coming days, be posted on Lung Saskatchewan's website on our Lung Life Patient Education web page. I want to take another moment here just to say a big thank you to Marie-Claude and all the wonderful people at GSK, our sponsor tonight, to make this happen. We're so grateful. And we hope you enjoyed the webinar tonight and that you'll join us for our final Lung Life webinar, which is Physio Yoga. It'll be a celebration of Lung Month. It's on November 22nd at 7 p.m. Central Standard Time. And you can register and find out more by just going to our website at lungsask.ca. So on that note, I hope everyone breathes easier this fall. And thank you so much and have a wonderful night.
Thanks everyone for watching. Bye-bye.